So to continue the debate and the discussion, foot arch revascularization, should we do it and how? This is again my disclosure. And the story of the foot arch revascularization is not so young, 13 years old. We started in 2009 with our first publication about the feasibility and the safety of the foot artery revascularization. Then we continued the study with the revascularization of digital arteries, feasibility and safety, and we demonstrated that supports the reduction of those amputation. Then again, in 2014, BTA revascularization is clinically useful and improves TCPO2 levels and wound sealing. Again, a novel interest in 2017 from vascular surgery in Italy. They could demonstrate the strict relationship between the arch patency and the wound healing, and this paper was published again on Korean Journal of Radiology, and they could demonstrate that the arch patency represents a key role for wound sealing. And in 2018, our friend Roberto Ferresi published this really important paper about the bed transmission and set distribution, demonstrated that arch and foot arteries failure represents a leading role in CLI. So the experience spreading all over the world about the revascularization of the foot arteries. This is the experience, the Japanese experience, and they could demonstrate there is a difference, a significant difference in the wound healing improvement in patient with the adjunctive angioplasty of the foot arch. The Egyptian experience in 2018, again, below the knee and below the ankle angioplasty can improve the clinical outcomes with accelerated wound healing in patient with CLI. The Chinese recent experience of this year, published in June, they could conclude their paper that patients with the impaired arch need a direct revascularization directed on the wound. So the question is, when we should need a foot arch revascularization. In our experience, we used to try the revascularization of the arch to improve the outflow in patient with an occluded arch when we have patient with the big artery disease. So when the amount of calcification in the foot is not so high, or in non-healing surgical wounds, or in patients scheduled for an aggressive surgery like the transmetatarsal amputation, or when we have foot ulceration involving more than one angiosome. So if we think that we have the arch occluded, a single vessel inflow, we will never help two different angiosomes, because we need a second vessel and a good distribution in the foot of the blood flow. And for conclude, no tibial outflow. So the previous colleague showed us the difference as the Cavarada classification of the foot arch, but I would like to show you again two ulceration in a critical limb ischemia patients in two different angiosomes, no single vessel in the leg, no tibial vessel, and no main vessel in the foot. In this case, we have to try to recanalize, of course, the tibial to have an optimal inflow, but even the arch to have an optimal distribution in the forefoot of the blood flow. The example, non-healing surgical wounds, you can see here non-healing wounds after an aggressive demolition of the forefoot with a previous history of FEMPOP bypass occluded. You can see here the situation in the FEMPOP area, the only anterior tibial artery working with several stenosis and the very poor situation around the wound. So the aggressive attempt to recanalize the posterior, the lateral plantar, the arch, in order to focalize the blood flow all around the wound. This is the perfusion angio demonstrating the efficacy of our procedures. How? So I mentioned before the escalation concept for the wire. So we have to use, of course, below the ankle and below the ankle and in the arch, in the foot, mainly 1/4 wires, and we have wire capable of navigation and wire with much more power to penetrate the occlusion, like the tip-loaded wire dedicated to CTO, like the Asato wire from Aasachi or Abbott Win, or the Cook approach CTO. You can see here a case with in the foot we have only a medial plantar artery. The lateral one going into the arch is occluded, and the 𝗓𝘴 pedis, the pedal artery, is occluded too. In this case, of course, we have to try to arrive as distally as possible in order to complete the distribution of the blood flow in the forefoot. And you can see how we try to maintain the wire in the middle of the calcium, but you can see how the 𝗓𝘴 pedis is really calcified, occluded, and very thin. The size of the artery is really bad, but this patient could be classified borderline between a patient with a big artery disease and a patient with the small artery disease. I remember you that the Ferraresi paper describes this population with a large calcification of the small vessel into the foot, so the distribution of the blood flow will be compromised despite a good revascularization of the tibial arteries. So you can see the concept of the wire escalation, and finally we could cross this occlusion with an Astato 20 grams, and when we arrive into the arch, we have to cross the lesion, of course, with the smallest balloon we have. Of course, if the balloon cannot cross, we can try to perform the piercing technique as I showed you before. Of course, we change the wire when we are in the foot. We shift to a navigation wire, and you can see how it's possible to arrive really in the distality, and when we have a patient with a lesion in the first, could be useful to arrive directly very close to the wound. And this is the acute result we may achieve after this aggressive foot revascularization. This is the anteroposterior view of the foot with a nice blush effect into the first toe. This is the correspondence, the perfusion angio. You can see here how efficient it was. To conclude, I would like to show you what is the meaning of an aggressive revascularization. Just to participate to debate, one is enough, two is better than one. When we have a patient with this kind of lesion, we cannot think one vessel is enough. Remember, because you have to perform an aggressive foot surgery. And if you perform an aggressive foot surgery, the foot wound has to be helped to heal. One vessel, it's not enough in this patient. And we could demonstrate that to have the same inflow of a distal bypass, we have to reopen at least 2 tibial vessels. This was published in 2008 and in 2011 by Italian group. So this is the angiography. There is only 1 vessel working, and the foot is completely desertic. So in this case, you have to perform an aggressive revascularization, subintimal revascularization of the anterior and the posterior tibial artery arriving in the foot. And as you can see, this is a very old case. We caused a distal atherovenous fistula, and Bruno, the talk of Bruno will clear us all the idea about this technique. And surprisingly, we consider this procedure a failure because the re-enter was in the vein of the arch. But look at the outcome of this patient, completely healed, really fast. So this patient still no symptoms. It's a patient of 10 years ago. So to conclude, my friends, when we consider foot arch revascularization, of course, when we have root 4, 5, and 6 big artery disease patients, so the transmission of the flow is good and the distribution of the blood flow into the foot could be good. When we have an impaired arch, or we need to improve the arch to have a better outflow, when there is a need for a transmetatarsal amputation of aggressive surgery, and be prepared for extreme retrograde approach when we have a complication, so distal digital puncture, and for sure consider that a long learning curve is needed. Thank you very much for your attention.